lessons, and these classes are very good and very crisp and concise in the precise amount of information that you need for your exams. And the notes that we have is based on the recent CBME curriculum, and MCQs are going to help you with your entrance examination. Okay. And you can also book a personalized counseling guidance with us. You will be given a mentor, and they will take care of everything. They'll give you a study schedule, they'll counsel you, and they'll make sure that you stick to the study schedule and pass your examination. And we offer 3 different subscription models: basic, standard, and premium. In the basic version, you have the pre-recorded videos, live class, and quick revision exam modules. Standard, pre-recorded live class, live doubt clarification, and quick revision exam modules. In the premium is like all-in-one kind of plan, which involves everything, including the one-on-one personalized guidance. You can use my coupon code Dr. Sushma 20 for any additional subscription. And this is the schedule that we have. And today is 11th April, GIT Development 1, where we are studying Foregut and the mid-cut. And tomorrow we'll be wrapping up the entire GI development. All right. So in yesterday's class, we studied the development of the human heart, right? In embryologically, how the heart actually develops. So this is what we saw. We saw that, how the atria and ventricles, when the cardiac looping takes place, right? After the looping, how the human heart, how the heart and the fetus rearranges itself, and how it starts pumping blood and contracting right by 5 to 6 weeks, isn't it? So we learned how the interatrial septum was formed, interventricular septum was formed, AV valves, and what are endocardial cushion, and all the different defects like patent foramen ovale and so on and so forth. Okay. Today is all about development of foregut, right? How the gut actually develops, basically, right? Stomach, how does it develop? How does the development of the stomach take place? I know this is not the stomach how it looks, but just bear with the diagram. So how the stomach, and we have the duodenum and everything, how it gets formed is all it is something that we'll be studying in today's class. All right. Yes, I hope you are remembering a little bit about basic embryology that we had done, right? I hope you at least now remember a little bit about the basic embryology. Otherwise, guys, what happens is, studying all of these things, right? I keep going back to the basics, the general embryology. So that is why be very thorough with the general embryo, and then so all of these things become really easy. Let's look at a clinical case scenario. We have a 40-year-old male who presents with chronic abdominal pain, especially after meal. CT scan reveals a midline cystic structure located anterior to the abdominal aorta and posterior to the stomach. Diagnosis of acute pancreatitis is made. What is the most common congenital anomaly of pancreas? The answer to this is actually pancreatic divism. We will see how the pancreatic divism is formed and what are the different congenital anomalies of pancreas. All right. Yes. Let's start with the development of alimentary tract. Now, guys, I told you the last time, the alimentary tract, the lining of the gut actually comes from the lateral plate mesoderm plus endoderm. Correct? That means the development is actually taken by these 2 layers. One is the mesoderm, another is the endoderm. Correct? Both together will give rise to my alimentary tract. Let us look at how it takes place. Alimentary tract develops from the primitive gut. Okay, primitive gut is formed due to incorporation of the dorsal part of the definitive yolk sac within the embryo when the embryo gets folded on itself at the caudal and the cranial ends, and it is also due to lateral folding. What does this mean, guys? We have heard the term yolk sac so many times, isn't it? We've heard the term yolk sac so many times. There is primary yolk sac, there is secondary yolk sac, there is definitive yolk sac. What does it mean is, let's say, when in the during the development, that's why I say general embryology is very important. We know that we have a cell layer called as epiblast cell, and this is the hypoblast cells. The epiblast cell they line the cavity, which is amniotic cavity, and the hypoblast cell, which is also called as a Huesner membrane, they line the cavity, which is called as yolk sac. Correct? This is what is the primary yolk sac that is formed very early in the development. Okay. After that, what happens? After primary yolk sac is formed, the mesoderm, which is the extra embryonic mesoderm, undergoes differentiation and it starts forming coelom around it, which is called as extra embryonic coelom. As the coelom becomes bigger and bigger, it actually eats off a little bit of this primary yolk sac, and now the secondary yolk sac is formed, which is smaller than the primary yolk sac. Okay, where is the yolk sac present? It is present in the Huesner's membrane, or rather, it is present in the the cells lined. What cells line the yolk sac? It is the hypoblast cells. All right. Secondary yolk sac is formed because of extra embryonic coelom. Then what happens? We have the formation of intraembryonic coelom in the lateral plate mesoderm, and that has got nothing to do with yolk sac. But once the folding of the embryo begins, the whatever the intraembryonic coelom that we had again eats off a chunk of the yolk sac. Now only a little bit of yolk sac is present in the embryo, and that is called as definitive yolk sac. Initially, the very first yolk sac cavity that developed was the primary yolk sac. Secondary yolk sac was formed due to the formation of the extra embryonic coelom, and the tertiary yolk sac or the definitive yolk sac is actually formed because of the folding. Okay, when the embryo gets folded on itself, it forms the definitive yolk sac. All my midgut, hindgut, foregut, all three structures are formed by my definitive yolk sac only. Okay, entire alimentary system is actually formed by the definitive yolk sac. Next, the yolk sac has two very important structures. One is the vitellointestinal duct and second is the allantoic diverticulum. The yolk sac has these two very important extensions which are called as the vitellointestinal duct and allantoic diverticulum. Okay, now it is closed anteriorly by the buccopharyngeal membrane and posteriorly it is closed by the cloacal membrane. Okay, does it make sense, guys? Obviously, anteriorly we have the mouth, posteriorly we have the anal canal, the entire gut, right? All of this, the definitive yolk sac which is formed is closed anteriorly by buccopharyngeal membrane and posteriorly by what? Cloacal membrane. Do we have a mesodermal covering? No, we don't have. These are the only two areas where the mesoderm is not covered. All right. Yes. Now the primitive gut has three parts. This primitive gut is all three parts are derived from the yolk sac itself. What yolk sac is it? It is the definitive yolk sac. Okay. If this is the yolk sac, as you can see clearly, you can see the allantois here, right? You can clearly see the allantois here, and also you can see the cloacal membrane, right? This side you can see the oropharyngeal membrane. Entire structure is the yolk sac. Anteriorly you see the oropharyngeal membrane. Posteriorly you see the cloacal membrane and also the allantois. Understanding? Very simple, guys. When you look at the diagram, most of the questions you can answer so easily, right? Foregut is the cranial part of the gut that lies in the head fold. This is the area of the foregut. Then midgut is a part of the gut that communicates with the vitellointestinal duct. So this area is the midgut. Hindgut is the caudal part of the gut that lies in the tail fold. So the midgut is the structure that communicates with the vitellointestinal duct. Vitellointestinal duct. Okay. Next, in the anterior intestinal portal, there is a communication between the foregut and the midgut. There has to be communication established, right? Otherwise, stomach and duodenum and ileum and colon, and how is it going to communicate with each other? So this communication between the foregut and the midgut is by anterior intestinal portal. Midgut and the hindgut is by the posterior intestinal portal, and the vitellointestinal duct disappears by the end of 5th week. Vitellointestinal duct was communicating with what? It was communicating with midgut. but it disappears by the end of 5th week. Okay, let's look at the foregut. So what have we understood, guys? Basically, where is all the structures coming from? It is coming from the definitive yolk sac. All the foregut, midgut, and hindgut structures are coming from the definitive yolk sac. How is the definitive yolk sac formed? After the folding of the embryo, again it takes off a major chunk of the yolk sac, and whatever the little yolk sac that is left out is the definitive yolk sac. Definitive yolk sac has very two important structures. One is the vitellointestinal duct, and another is the allantoic membrane. Posterior to the allantoic membrane is what we have the caudal end, right? In the posterior area, we have the caudal end, and in the anterior area, we have the buccopharyngeal membrane. So this entire structure is what I am calling is what is called as the definitive yolk sac. Did you understand what primary yolk sac was? The initial, somebody has their mic on, please turn it off. The primary yolk sac was formed initially, very initially. After the blastocyst was formed, I discussed that there is a, what is this? Epiblast layer, and there is a hypoblast layer. And the very first structure that is formed is the primary yolk sac. After that, as the extra embryonic coelom started developing, the coelom around this is the extra embryonic coelom. As it started developing more, what happened? It took away the chunk of the primary yolk sac. Primary yolk sac became even more smaller, and that formed the secondary yolk sac. When was it? After the extra embryonic coelom was formed. The definitive yolk sac is formed when the embryo got folded on itself. Right? Yesterday also I spoke about how heart tube fuses and it forms a loop, and that's how the atria comes up and ventricles come below. Similarly, here also the embryo actually fuses on itself. That is why the heart tube area, the cardiac area actually, which was right in the front, the cardiac area is here, that comes down because of the folding of the embryo. When the folding of the embryo takes place, again a little bit of yolk sac is taken out. Now we have, finally, after the folding, we have the definitive yolk sac. Definitive yolk sac is what is giving rise to midgut, foregut, and hindgut. Understood this? Understood the concept? Very easy, guys. If you have understood this much, then I think for us, from here to go, it becomes very easy. In the yolk sac, how does the definitive yolk sac look like? We have two membranes. One is the buccopharyngeal and cloacal membrane. Buccopharyngeal membrane, is it covered by mesoderm? When we are discussing about how the mesoderm spreads everywhere, it does invagination. Remember that? It goes, it goes and replaces all the endoderm. It replaces the epiblast layer and it spreads everywhere. Even it communicates with the extra embryonic mesoderm. But the entire, structure gets spread by the mesoderm except for two structures. One was the buccopharyngeal membrane, the other was the cloacal membrane. Similarly, the definitive yolk sac now has buccopharyngeal membrane in one end, which forms the mouth, and the cloacal membrane in the other end, which forms the anal canal. Between that, we have the development of the gut. Development of midgut, foregut, and hindgut. All three are coming from the yolk sac only. What yolk sac? Definitive yolk sac. Understood? Yes. Yeah. Then we'll go to the development of foregut. Development of foregut. Now, what is the extent? What is the extent of the foregut? It extends from oral cavity to a point where common bile duct opens into the duodenum. That is till the major duodenal papilla. This is very, very important, guys. All of us make one mistake. Whenever I ask students, what is the extent of foregut? We say from oral cavity till ligamentum of we say that the oral cavity extends from the the foregut actually extends from the oral cavity to the major duodenal papilla. Okay, but there is a difference. There is a difference here. There is something called as ligamentum treats. What is this ligament of treats? What is this? Ligament of Treats. Ligament of Treats is that one structure which actually decides whether it is a upper GI bleed or a lower GI bleed. All of us make a mistake in this and we think that the extent of foregut is still the ligament of Treats, but it's not. Ligament of Treats is what decides whether the bleed is upper GI bleed or lower GI bleed. Okay, the extent of foregut is still the major duodenal papilla and not the ligament of Treats. Ligament of Treats is not that differentiates the extent of foregut and extent of midgut. Okay, extent is determined by the major duodenal papilla, that is the common bile duct which opens into the duodenum. Ligament of Treats is considered as a landmark to say if the bleed is upper GI bleed or lower GI bleed. Upper GI bleed features are, guys, there will be hematemesis. Lower GI bleed features are melena. Upper GI bleed is seen in case of what conditions? Example, esophageal varices is there, and liver failure, hepatocellular carcinoma, portal hypertension. The many conditions where upper GI bleed is seen. Lower GI bleed is seen in case of, let's say, hemorrhoids, very common, anal fistula, CA colon, so many conditions, ulcerative colitis, and so on and so forth. So ligament Treats is something that determines if the bleed is upper GI or lower GI. But that is not the one that determines the extent of foregut and midgut. If I have to talk in from the point of view of embryology, it is the major duodenal papilla that decides the extent of foregut and midgut. So what are the derivatives? Whatever that lies from oral cavity till the major duodenal papilla or till the the point at which the bile duct opens becomes the foregut. Pharynx and its derivatives, right? Oropharynx, nasopharynx, tonsils, salivary glands, lower respiratory system, esophagus and stomachs, duodenum proximal to the opening of the bile duct, of course, liver, gallbladder, extrahepatic biliary apparatus, and pancreas. So all of these are the derivatives of the foregut. Then, from the opening of the bile duct in the duodenum to the junction of 2/3 right side and 1/3 of the transverse colon. Between the major duodenal papilla and the junction of 2/3 and 1/3 of transverse colon, we have the midgut. Above that, we have foregut. Here we have the midgut. Now, what are the derivatives? Very easy. Duodenum below the opening of the common bile duct, jejunum, ileum, appendix, cecum, ascending colon, right colic flexure, right? This portion also. And we have the right 2/3 of the transverse colon. Understanding? Hindgut is from here, whatever that is there. Let's say the left 1/3 of the transverse colon, if I have to point this much, left colic flexure, the descending colon, you have the sigmoid colon, rectum, upper half of the anal canal, and the primitive urogenital sinus derivatives. So from oral cavity till major duodenal papilla is the foregut. From major duodenal papilla till the junction of 2/3 and 1/3 of transverse colon is the midgut. Below the left 1/3 of the distal 1/3 of the transverse colon is hindgut. Okay, these derivatives are very important. You have to know the extent as well as derivatives. Okay, then it becomes very easy for us. All right. Now, which structure forms the boundary between foregut and midgut during embryonic development is major duodenal papilla. And it is the point at which the bile duct opens into the duodenum. If this is a duodenum, guys, the C-shaped organ. And if here I have the, let's say this is the gallbladder, and the point where the bile duct comes and enters the duodenum is where the is where exactly the landmark for differentiation of midgut and hindgut. Let's talk about mesenteries of GIT. Now, guys, I have stomach. Let's say if this is the human body, okay? Let us say this is a very bad, dirty diagram. Please bear with my bad drawing skills, okay? I try to improve, I promise, but I, of course, I can't promise. Right, this is the human being. Okay, very simple Sasta Tikau diagram that we all make. Now, if this is a human being, and now I have the stomach over here, let us imagine that this is the stomach. How is the stomach attached to the body wall? Right? How is the stomach, or let's say liver, let's say spleen, how are all of these organs attached to the body wall? These, especially the gut, the entire gut is attached to the body wall by the ventral and dorsal mesenteries. Okay. Now, the ventral mesentery exists only in the terminal part of the esophagus, stomach, and upper part of the duodenum. Okay. Because let's say if this entire, I have the body wall like this, which is covered by the ventral mesentery, right? It is entire body wall is covered by the ventral mesentery, and I have the esophagus which is attached to the body wall via this ventral mesentery. But what happens? I have the growth of the liver over here. Is it not? Let's say if this is the body wall, and which is completely covered by the, which is completely covered by the mesentery like this, which is attaching the, for example, if I have to say, if it, let's say it is attaching the, let me take a different color. Let's say it is attaching the esophagus here, stomach here, all of the midline organs. But I also have a liver which is coming like this. Is it not? There's a liver which is developing like this. This developing liver divides it into lesser omentum and falciform ligament. Very, very important. There is one ventral mesentery like this covering the body wall and attaching all the different organs like esophagus, stomach, and upper part of the duodenum. But the liver is coming like this, which divides it into lesser omentum and falciform ligament. Understanding, guys? Understanding? Yes. Look at it. Look at it. This is the falciform ligament and this is the lesser omentum. And here you can see the developing liver. And this is, of course, the stomach and duodenum, which are attached to the body wall like this. This is the developing embryo, as you can see here. Okay. Next, there's something called as dorsal mesentery, which suspends the caudal part of the foregut and midgut and major part of the hindgut from the abdominal wall. Ventral is till the duodenum. Dorsal is from duodenum below down, right? And it forms dorsal mesogastrium, mesoduodenum, dorsal mesentery, and dorsal mesentery of jejunum and ileal loops, which is called as mesentery proper, and dorsal mesocolon. Dorsal mesocolon. Okay, understood? What is ventral mesentery? Till the duodenum, and the liver comes like this and divides it into lesser omentum and falciform. Then we have the dorsal mesentery below the duodenum. You have all of these structures: dorsal mesogastrium, mesoduodenum, and mesentery proper, and dorsal mesocolon. Okay, this is very important. You have to know what ventral mesentery is and just whatever the concept that I have told you. Okay, next, let's go to a very important concept, which is the blood supply of GIT, which is the blood supply of GIT. Now, mainly the blood supply to the GI comes from the dorsal aorta. Okay, it is the aorta that gives rise to all different arteries that supply. What is that aorta? Abdominal aorta. Is it or is it not? Thoracic aorta can't come here, no? This is the abdominal aorta from where different branches come. The first branch that arises is the celiac trunk that supplies the foregut. Superior mesenteric artery supplies the midgut. Inferior mesenteric artery supplies the hindgut. This is very, very, very important to understand. Okay, entire gut GI tract is supplied by abdominal aorta. Is it not? Right? The first branch that supplies the different structures in the foregut is the celiac trunk. Then, of course, in the midgut, we have superior, right? Superior is always higher. In the hindgut, we have inferior mesenteric artery. Celiac trunk, superior mesenteric artery, inferior mesenteric artery that supplies the hind gut. Okay, understood? So what have we learned so far? We have learned that how the gut is formed. This is very important. Okay, how the gut and from where the gut is coming. That's the first question that we've learned. Second, we learned what mesentery is. Again, that's a very important concept to understand. Third, blood supply of GI. Okay, blood supply of GIT. This is a for sure question. It will be asked in your exam in one way or the other. Whether in practicals, in your theory examinations, it is for sure asked. And fourth concept that we learned is derivatives of midgut, hindgut, and foregut. In these derivatives, the extent is also very important. Okay, extent, derivatives, blood supply, mesentery. Four concepts done. Let's go further. What is the primary arterial supply to the foregut during embryonic development? Foregut is celiac trunk. Celiac trunk comes from abdominal aorta. Okay? Yes. You can say, sometimes you can argue why is it not aorta, because celiac trunk comes from aorta only, but celiac trunk is a more specific answer. Of course, it comes from aorta. Of course it is, but celiac trunk is a much better answer. It cannot be superior mesenteric because it forms midgut, inferior forms hindgut. So, better answer over here would be celiac trunk. Nothing is wrong if you say aorta. Of course, everything is supplied by aorta only, but celiac trunk is a better answer over here. Okay. Next, let us look at the development of esophagus. Now, esophagus basically is a muscular tube, right? It's a muscular tube that is responsible for pushing of the down from the oral cavity till the stomach. It is a tube that carries food from oral cavity to stomach. Okay. Next, is it a part of foregut, midgut, or hindgut? It lies above duodenum, so it is a part of foregut. Extent of esophagus between pharynx and stomach. Correct? This is basic, right? This should be the opening statement whenever you write. What is the, whether it comes from foregut or midgut or hindgut, and what is the extent? These 2 points you have to write. They are the opening statements. Then, at the 4th week of intrauterine life, the tracheobronchial or respiratory diverticulum appears in the caudal end of the pharyngeal foregut. It appears in the caudal end of the pharyngeal foregut. Soon after, what happens? This tracheoesophageal fold and septum develops that divides it into ventral trachea and dorsal esophagus. Okay, there is a common structure which is there at the end of 4th weeks, which appears in the ventral aspect of the foregut at the caudal end of the pharyngeal foregut. Correct? What is that structure? Tracheobronchial or respiratory diverticulum. Tracheobronchial, it has both. It has trachea, bronchial or respiratory diverticulum. Soon after, tracheoesophageal fold and septum develops, and that divides it into 2 parts, ventral trachea and dorsal esophagus. So guys, ventrally what do we have? Like, if you look at right now, in a developed human being, ventrally you have the trachea, dorsally you have the esophagus. Why is it happening? Because soon after the development of this tracheobronchial septum and fold, it divides the suppose if this is the tracheobronchial diverticulum, respiratory diverticulum, and a septum comes here that divides it into 2 parts, that forms the ventral trachea, dorsal esophagus. Correct? Initially, the esophagus is short but elongates due to the formation of neck and descent of the diaphragm, lungs, and heart. Correct? Now, suppose if this septum is not there, or there is some defect in the formation of the septum, or if some parts of the septum got resorbed for some reason, then there will be a communication between the trachea and the esophagus, which is called as tracheoesophageal fistula, which is a part of the very famous defects called as bacterial defects. I am sure you will learn all of this when you come to your surgical classes, but know that there is a septum that divides the respiratory, this tracheobronchial or respiratory diverticulum, like what I have drawn over here, and that separates the trachea and the esophagus. If suppose, let us say that the resorption of the, resorption of the septum has taken place, or at sometimes it's not properly developed. That is what causes this communication between the trachea and the esophagus. You can see this trachea is in blue color, esophagus is in pink color. Ideally, it should be like this, is it not? It should be like this. There is no communication between the esophagus and the trachea. But now see what is happening. There is a communication between esophagus and the trachea because of non improper development of the septum, and these defects are called as tracheoesophageal fistula. Tracheoesophageal fistula. Okay, next, this is one of the problems that can happen, one of the anomalies, developmental anomalies of esophagus. But what if there is a complete esophageal atresia itself? Due to the deviation of the tracheoesophageal septum in the posterior direction or failure of recanalization of the esophagus itself. What suppose if let's say the septum was supposed to divide it into equal half. So anteriorly I have trachea, posteriorly I have the esophagus, but because of some deviation of the development of the septum, my esophagus may not even develop at all, or at some proportions it may not develop at all. That is called as esophageal atresia. That is called as esophageal atresia. Two very important developmental anomalies, guys. Right? Next, third is achalasia cardia or cardiospasm. This happens because of the lower esophageal sphincter fails to relax. This is not, this is again, there are many reasons why this happens, but the main reason is loss of ganglionic cells in the Auerbach's plexus. There are two plexus, right? Mesenteric plexus and myenteric plexus. I hope you know all of these things. Otherwise, you will have to learn, because those are all the very important things that you learn in histology, right? Next, achalasia is due to loss of these ganglionic cells in the Auerbach's plexus. So, what are the anomalies of esophagus? Tracheoesophageal fistula, atresia, and there at some places there may be stenosis also, and we have achalasia cardia. In achalasia cardia, you see a very classical bird beaks appearance on barium meal. Classical bird beak appearance is seen. Then you inject some botulinum toxin and all here so that the muscles relax. It causes GERD, recurrent reflux will be there in case of this achalasia cardia. Okay, understood the development and the developmental anomaly of the esophagus, which is very, very important, guys. There is no way that you should understand the development of esophagus, but because it will help you immensely in your surgery, right? In surgery, there are so many things that you learn in the chapter of the esophagus, that there are so many, some 15-20 conditions that you learn. Okay, next, let's go into the development of stomach, which is a very interesting class. Okay, stomach develops during the 4th to 5th week as fusiform dilation of the part of the foregut. This is the opening statement. As a fusiform dilatation of the part of the foregut, of course, distal to the esophagus. Now, this fusiform sac has right and left surfaces and ventral and dorsal borders. Okay, rotation, mesentery, all of this is a much important concept, guys. I think I'll probably teach stomach in the next class, because I need to explain it, and I'll probably do other structures, simpler ones like liver and spleen, because this is a very important concept. I at least need 20-25 minutes to explain this, mesenteries of stomach and how they are formed, and formation of lesser sac, the omental bursa, and everything. I'll do one thing. I'll teach stomach, development of stomach in the next class. Anyway, we are covering GIT only, but we'll just finish off simple things like development of liver, but stomach is very interesting. It will be done in tomorrow's class. Okay, 12th April, we'll do stomach. I'll make sure that I'll start with stomach in tomorrow's class because it's going to take some 25 minutes minimum to understand the development of stomach, which is where you get majority of the questions. I don't want to rush through. Today, we'll do simple topics like liver and spleen and everything. Okay, here it's not very difficult. Now, guys, we mainly have two sources for liver. One is endodermal liver bud, another is septum transversum. Now, what is this septum transversum, guys? Septum transversum is the undifferentiated lateral plate mesoderm. If I have to revise everything once, what are the different derivatives of the mesoderm? We basically had the notochord here. Then we had para-axial mesoderm, which formed the somites. Somites formed so many structures, right? The muscles of back and the dermis of the back and intercostal muscles and everything. Then we had intermediate mesoderm. Intermediate mesoderm gave rise to gonads and genitourinary system. After that, we have lateral plate mesoderm, which again got divided into two parts. There is splanchnic and parietal part. And because of the formation of intraembryonic coelom, the splanchnic, which is the the inner part of the lateral plate mesoderm, along with endoderm, gave rise to lining of the gut. If you remember, this is what we had discussed. That is what we are discussing here also now. Endodermal liver bud. Liver bud is coming from endoderm. Combines with septum transversum. Septum transversum is undifferentiated lateral plate mesoderm. Is it not? This is something we studied while studying the pharyngeal arches and somites, isn't it? Lateral plate mesoderm along with endoderm give rise to lining of the gut and so many different structures. So liver comes from endodermal liver bud and lateral plate mesoderm, which is the septum transversum. Okay. Now, what are the different structures of the liver that come from the endodermal liver bud? It has hepatocytes and intrahepatic biliary apparatus, whatever that is there inside of the cell. Suppose if I have to look at the liver parenchyma like this, we have hepatocytes, right? Hepatocytes, and there is a central canal, and there's a portal triad, and all of these structures are there. And there are Kupffer cells, and it is covered by a fibrous capsule. Remembering, this is a very famous diagram that we all keep writing in first year. So, of course, the mesoderm is a much outer layer and endoderm is a much inner layer, right? So whatever the interior of the liver, like the heparitis and the intrahepatic biliary apparatus, comes from the endodermal liver bud. Whatever is there outside, like the fibrous capsule, Kupffer cells, blood vessels, they all come from the septum transversum. Easy to remember. Apply logic, right? Very simple and easy to understand. Vitelline and umbilical vein forms the sinusoids. Ventral mesentery forms lesser omentum, falciform coronary and triangular ligaments. This we have already seen how mesentery, how the developing liver divides the mesentery. Okay, next. The hepatic trabeculae differentiate into solid plates of liver cells and it forms the liver parenchyma and lining of the biliary canaliculi. Vitelline and umbilical vein lying in the septum transversum break up into a capillary network and it forms the hepatic sinusoids. All right. Next, the mesenchyme of the septum transversum, that is lateral plate mesoderm, they actually form the hematopoietic cells, Kupffer cells, connective tissue cells, obviously blood vessels and capsule of liver. Capsule of liver. This differentiation is important. Then, what is the development of gallbladder and biliary apparatus? Gallbladder and cystic duct, it develops from the cystic bud. Okay. Right and the left branches of the pars hepatica become canalized to form the right and left hepatic ducts. Hepatic ducts are coming from pars hepatica. Okay. Next, these right and left hepatic ducts join together to form common hepatic duct. Common hepatic duct. Now, common hepatic duct is joined by cystic duct to form common bile duct, which is called as CBD. CBD. Okay, what is the concept here? Right and left hepatic ducts join together to form common hepatic duct. Common hepatic duct is joined together by the cystic duct to form the common bile duct. Cystic duct brings the bile from gallbladder. Is it not? Yes. Now, extrahepatic biliary apparatus is endodermal in origin, right? Now, the differential growth of the duodenal wall, it actually pushes the opening of the common bile duct from the ventral aspect to dorsomedial aspect of duodenum along with ventral pancreatic bud. So now this differential growth of duodenal wall itself actually is what is responsible for the fusion of the dorsal and the ventral pancreatic bud. But we'll see how it happens in next class, not in today's class. Okay, let's just look at the anomalies of the gallbladder. Anomalies of the gallbladder. Septate gallbladder. Suppose if this septa is present here, if it does not, if it doesn't get resolved, it forms septate gallbladder. Double gallbladder, if it goes all the way, it looks like as though there are two gallbladders present. It is something like septate uterus. You know, if you have to draw an analogy here, initially how the uterus develops, it develops from two Mullerian ducts. Later, what happens? These two Mullerian ducts, they fuse craniocaudally, right? And then they have a septum in between. Similarly, and the septum gradually starts getting to resolve. There will be resorption of the septum, which results in the formation of one uterine cavity. So initially, you have something like this. If you have to draw parallels to uterine development, I'm sure it will be too much for today's class. But anyway, just coming back to the gallbladder, right? You can easily revise once today after going back to see how the development of the uterine cavity takes place. How from two Mullerian ducts, how it from Didelphi to septate uterus to bicornuate, all of these things you have to go back and study once. Okay, then we have double gallbladder. If there is completely two gallbladders are present which are connected by the cystic duct. All of these are developmental anomalies. Okay, floating gallbladder is lined by peritoneum on both surfaces. Right? Now, what are the anomalies of the extrahepatic biliary ducts? Extrahepatic biliary ducts is whatever that is there, like cystic duct and CBD, and all of these are extrahepatic biliary ducts. Where are they coming from? Endoderm, remember. Atresia of ducts. The ducts of the extrahepatic biliary apparatus may be partially or completely absent. If there is atresia, what happens? If there is extrahepatic biliary atresia, what does it mean? In a newborn, the bile is not getting excreted at all. There will be a lot of accumulation of bile because of newborn presents to you with jaundice, abdominal distension. Jaundice, the bilirubin crosses even 15 and 20. Will it be conjugated or unconjugated? Conjugated bilirubin. There'll be too much of bilirubin in the body. Is it not? Too much of bilirubin reaching 15, 20, you start phototherapy, still, it is not, the bilirubin levels are not coming down. Then you go for exchange transfusion, still it's not coming down. Then there is abdominal distension. All of this together points towards one thing. There is extrahepatic biliary atresia. Okay, and what do we do? Which procedure do we do? It's something called as Kasai procedure, which is done in those cases. I mean, just for your information, you need not have to do it. But there is a condition called as extrahepatic biliary atresia, for which we do something called as HEDA scan. Okay, in HEDA scan, you inject a dye to see if the dye is coming out or not. If the dye comes out, yes, the biliary apparatus is fine. Dye does not come out, then there is some obstruction somewhere. Is it not? Yes. So this is the extrahepatic biliary atresia, which is a developmental anomaly. Okay, understood. I know this class is a little too much. I mean, I can see that I might have combined a lot of surgery, medicine, and OBG together in this one simple class. But the reason why you have to know this is because I keep saying anatomy is like the foundation for everything. Foundation for surgery, foundation for OBG. If your anatomy is strong, then whatever the clinician that you're going to become will be very better. You become a very good clinician if your basics are strong. Okay. So today we are left with pancreatic development and development of stomach, which are very important, guys. And I don't want to rush through how the development of pancreas and how the stomach development takes place, and the developmental anomalies, the rotation of the midgut. All of this is very, very interesting. I don't want to rush through. I'll take these two up in the next class. Okay. And for now, let's just revise whatever we have learned until now. What did we learn? We actually spoke about this question is dorsal pancreas is a different topic that we'll do tomorrow. So what did we learn? We learned how gut is formed. We learned derivatives of the gut. Is it not? We learned the gut and its derivatives and its extent. Then we learned about mesentery. Then we learned how esophagus development is formed. Then we learned, what else did we learn? What else did we learn? Then we learned how liver and extrahepatic biliary apparatus development. Okay, all of these are very important, guys. These are all potential questions in theory as well as in practicals. All right, I wish you guys all the very best, and just keep studying. In tomorrow's class we are doing 12th April. We are beginning with stomach, and we'll then do pancreas. These two are very important, and then we'll go to hindgut development. Okay, so tomorrow's class will be stomach and pancreas, which is a part of GIT only. Thank you so much, guys. Thanks a lot. Thanks for staying, and I wish you guys all the very best. Keep studying, keep reading. I'll see you tomorrow. Bye bye.